Hello?
Hello?
Hi, this is Matthew here.
How are you doing? I'm Joseph Grignon. How are
Hi,
you doing,
I'm
Matt?
great, thank you. How are you?
Fine.
Cool.
You're in the lab.
Thanks for joining on the call and for your time. I'm not sure what GLG told you, but I'm a healthcare investor, and I was looking at Hansa and wanted to discuss their products and the data available in the
Yeah.
context of
Yeah,
kidney
yeah.
transplantations.
Yeah.
So it'd be just great to get your background, and then we can dive in.
Okay. Mm-hmm.
So, could you just give me a little kind of introduction to your current kidney transplantation protocol and how, if at all, you would see this product fitting into that?
Okay. So what's happening nowadays is that the number and proportion of patients, so-called highly sensitized, let's say patients who have a high percentage of anti-HLA antibodies, this proportion is increasing because the transplant programs are relatively ancient, and because of that we have many candidates in this situation with difficult access to transplantation.
Yeah.
Yeah, so having said that, the common protocol used in this kind of patients is to perform, as you may know from other consultants, plasmapheresis and intravenous immunoglobulin, the so-called IVIG. This is the current standard protocol used in our unit and in many others. You may also know that there are some variations on this strategy, adding plus minus rituximab, and even some colleagues use some plasmapheresis even after transplantation. So the current standard for this kind of patients is what I said. But this is a consensus current standard. It's
Okay.
not an approved regime by the regulatory agencies.
Okay. So, in terms of how successful that protocol is, can you kind of describe the current rejection rates and how you kind of view this as a unmet medical need?
Yeah, the usual rate of rejection in these patients is relatively higher as compared to other conventional, the so-called standard risk patients. So, and maybe around 30% or antibody-mediated rejection. So these patients many times need intensive treatments after transplantation, again using plasmapheresis and IVIG and rituximab. The main concern about these rejection episodes in these patients is that despite the control of the acute episode, some of these patients may develop chronic lesions mediated by antibodies in a more insidious process, leading to chronic antibody-mediated rejection.
Okay. And so if I can paraphrase then, would you suggest that acute AMR is relatively easy to control, but the chronic rejection is a much harder to get under control?
Exactly, and it's much harder to control. It's a chronic process, so we can use iterative rescue therapies because of the risk of cumulative immunosuppression, too much immunosuppression with the risk of opportunistic infections. And on the other hand, at times it's difficult to really evaluate the benefits of addressing this chronic antibody-mediated rejection in the midterm. This has been the challenge of some companies aiming to prevent the so-called transplant glomerulopathy.